Linking evidence to clinical practice, snapping hip. Snapping hip is a vague term described in the literature as an auditory or palpable snapping with hip movements. Clinically, I've observed patients describe a snapping at the front of their hip when extending it from a flexed position. Typically, this is during a core stability exercise in patients with low back pain. The snapping is more prevalent with increasing stability challenge despite no alteration in range of movement. This leads me to consider that this indicates that it's due to a functional or load impairment rather than being pathological. I would question why this occurs with hip extension rather than flexion and as the exercise becomes more challenging. I'm often asked by my patients if their hip snapping is something to be concerned about. Some literature suggests that the most frequent presentation is a non-painful snapping, which is a normal variant and not indicative of future problems and therefore not a clinical concern. However, it can also be associated with iliopsoas bursitis, tendinitis, groin pain, and low back pain. Although I often observe hip snapping in the clinical setting, there are many examples in the literature. Hip snapping is estimated to occur in 5 to 10% of the general population. The incidence is thought to be higher with associated signs and symptoms in dancers, footballers, and runners. Winston et al. Showed in a cross-sectional study, level 3 evidence, of 87 elite ballet dancers, 91% of whom reported signs of snapping hip, with 58% with associated symptoms of pain, that on ultrasound examination the iliopsoas tendon snapped in 59% of hips. When persistent pain is associated with the condition, repeated injections and surgical release have been advocated. In a study by Holmick et al., the iliopsoas-related pain was by far the most common secondary clinical entity associated with athletes with long-standing groin pain. Groin pain is a significant issue in many of the sporting population and can be career-changing. Lewis reports from a literature review that the prevalence of snapping hip is higher in females. Could this be related to the larger angle in the female pelvis? Lewis also noted that a possible confounder was also the higher prevalence of intra-articular pathology seen in females. I would question whether the two observations are linked rather than being seen purely by chance. Is the snapping an early indicator of potential problems? Is the onset of associated pain something we can avoid by avoiding the snapping and potential microtrauma? If the snapping can be explained by movement of the tendon over the iliopectineal eminence with the bursa lying in between the structures, then is there potential for the bursa to become irritated as seen in other pathologies? The aims of this project are to determine whether there's evidence to suggest hip snapping is an indication of dysfunction in the hip or lumbar spine, and to link the evidence to clinical practice. The objectives are to review the source of the snapping, the anatomy of the psoas major muscle, the function, biomechanics and neurophysiology, and the mechanisms that might affect the hip snapping. The psoas major muscle has fibrous attachments and individual fascicles. Anterior and posterior unipennate fascicles which orientate infralaterally and come together as a common tendon which descends over the pelvic rim, sharing a common insertion with the iliacus on the lesser trochanter of the femur. The separate nerve supplies for the anterior and posterior fasciculi suggest a different function. This project acknowledges that although the ilio and psoas have a common insertion, the muscles can be considered separately. They've been shown to have individual and task-specific activation patterns. This project will focus on the psoas major as the hip snap has been observed to be affected by mechanisms that can reinforce its role. Psoas has extensive fascial connections. The literature lists several areas around the hip that can cause a snapping. The area that I'm questioning has been described in relation to the hip joint as anterior, internal and extra-articular, specifically the iliopsoas tendon as it moves over the iliopectineal eminence, or anterior femoral head and capsule. Mechanically, the iliopsoas tendon moves from lateral to medial, from a hip flexed, abducted, externally rotated position to a relatively extended and internally rotated one. The critical angle for this shift is approximately 45 degrees, where a change in course of the tendon is seen, or described as 30 to 45 degrees in Lewis's review. Tattoo et al. Questions which structure transiently impedes the translation of the tendon and suggests there's no clear explanation of factors contributing to its occurrence or reasons for it causing pain. Clinically, it's important to differentiate from other sources of noise from the hip joint. Intra-articular pathologies are associated with catching, locking and sharp stabbing sensations, and the hip quadrant test could indicate hip joint pathology. Through attachments and anatomical relations, the psoas affects the lumbar spine, hip and SIJ. There are many studies that have investigated the biomechanics of psoas. However, the results are limited due to unsubstantiated assumptions and the use incorrect and incomplete anatomical models. There is consistency that the primary force on the lumbar spine is axial compression, which is reported to be from the anterior fasciculi. This will contribute to segmental stiffness and resist shear forces. Due to mechanics and the axis of rotation, the small amount of extension at L1, 2 and 3 and flexion at L4 and 5 resembles a neutral lumbar lordosis. As psoas is a unipennate muscle with fibre lengths of between 3 and 8 centimetres, the ability for it to shorten is less than originally believed, and therefore its role as a hip flexor is questionable. However, Hugh et al. State that because the psoas passes anterior to the flexion-extension axis of the hip, that mechanically it is a hip flexor. Yoshio et al. Conducted a kinetic and morphological study using cadavers. They concluded that the primary role of psoas was lumbar stability, and it contributed very little to hip flexion. The primary role of psoas at the hip was stability, achieved by maintaining the femoral head in the acetabulum. Hugh et al. Studied the role of psoas in the active straight leg raise and concluded that as the contralateral psoas is active, that it probably contributes to stability of the lumbar spine in the frontal plane. However, the ASLR was performed so the foot lifted to 20 centimetres above the table, and therefore the results cannot be directly extrapolated to this project, due to the observation being at a slightly higher angle of flexion. Instead, this study adds to the indication of psoas's role. As the psoas crosses the pelvis, it must exert a force on the sacroiliac joint. The psoas contributes to force closure of the SIJ through axial shortening. This is described as an anterior sling mechanism. Clinically, this is relevant. If the psoas is contributing to force closure at the SIJ, then if functioning optimally, the pelvis acts as a unit and contributes to a mechanically stable situation for the hip to rotate. If the pelvis is not functioning with force closure, then rotation of the anomalates may affect function at the hip. There is conflicting evidence in the literature regarding the function of psoas and innominate control. However, the contribution of rotation is thought to be dependent on sufficient force closure. In this clinical scenario, is psoas working as a hip stabiliser, hip flexor eccentrically, and/or lumbar spine stabiliser? My personal clinical observation suggests the snapping can be reduced or eliminated by force closure, AP glide to the hip, psoas training as a hip stabiliser, or reducing the demands of the exercise. My hypothesis being that if psoas is challenged in one of its roles, then it may be unable to control elsewhere, and one indicator of increased control at the hip is objectively seen as a snapping. Gibbons states that when the demands of the hip are increased, the mechanism will automatically augment stability in the lumbopelvic region. What factors might influence hip snapping? Lee states that timing delays in recruitment of psoas during hip flexion is seen in patients presenting with clicking hips, which is associated with hypertonicity of the superficial hip flexors, thought to create a net vector of force that decentralizes the femoral head. Lewis et al. Used an MSK model to determine a theoretical base regarding the anterior hip forces relative to muscle activity and position. There are obvious limitations and assumptions, however, the results can be appreciated from a clinical viewpoint. That when TFL or RecFem is dominant in hip flexion, that there is increased anterior force placed on the hip joint, the magnitude of which increases as the angle of extension increases. They describe iliopsoas as similar in concept to the rotator cuff muscles, stability forces acting on the hip joint by the muscle belly and tendon. The tendon moves over the iliopectineal cements from externally rotated position towards a relatively more internally rotated position. So if the mechanics are influenced by an imbalance in muscle forces, could this contribute to a snap? Johnston et al. Reported an improvement in symptoms of iliopsoas syndrome, pain with or without a snap, with a rotator strengthening program. Although the study was small and not specific to objective findings, they concluded that the program had a significant effect on reducing pain and improving functional outcomes. The study also included stretching to the muscles around the hip. The conclusion that can be drawn from this study is that a global increase in rotational control can be part of the management to reduce signs and symptoms in iliopsoas syndrome. Gibbons et al. Described the biomechanics and stability mechanisms of psoas following dissection of 4 cadavers. Through axial shortening, the psoas contributes to force closure of the SIJ, which could be considered as a sling. Additionally, psoas can be considered in 2 parts. Posterior fascicles can be thought of having a local stability action, segmentally in the lumbar spine, while the anterior fascicles are better suited to a global stability role, acting over the SIJ and hip. A cylinder model is often used to describe the core stability concept in the lumbar spine. Through its fascial attachments, the psoas links the diaphragm to the pelvic floor and can be visualized as a rod in the middle of the cylinder. Gibbons also describes the fascial links with the diaphragm, pelvic floor and transabs and suggests they have an important role in contributing to functional stability. Review of the aims. There may be many factors associated with the observation of hip snapping. This project has only considered what is thought to be the most directly related. However, I acknowledge that many additional significant factors may have been unintentionally ignored. When determining whether there's evidence to question whether hip snapping is an indication of local dysfunction in the hip or spine, there is no direct evidence. However, hip snapping is often associated with athletes with additional pathologies and pain. When linking the evidence to clinical practice, the common compensatory mechanisms I see are the increased abdominal activity, decreased lumbopelvic stability, hypertonicity of anterior hip muscles and timing delays in psoas recruitment, and the common correction strategies I use: improve force closure, psoas major activation, reducing the demands of the exercise, and hip rotator strengthening.